Well, it was only a matter of time before artificial intelligence would make its way into prostate cancer. Artera.ai is the new AI approach approved by the NCCN to help radiation oncologists and physicians figure out if a patient needs androgen deprivation therapy for prostate cancer while they undergo radiation therapy. Today's conversation is with one of the authors and one of the main papers on artera.ai, Dr. Daniel Spratt. Dr. Spratt is the chairman of professor of radiation oncology at the University Hospital's Seidman Cancer Center and Case Western Reserve University. He obtained his medical degree from Vanderbilt Medical School and completed radiation oncology residency at Memorial Sloan Kettering Cancer Center here in New York. He served as the vice chairman, Department of Radiation Oncology, and chair of the genitourinary clinical research team at the University of Michigan until April 2021, when he joined Case Western Reserve University. Dr. Spratt is a renowned radiation oncologist in the world of prostate cancer and has written many papers, many peer-reviewed papers on the topic. Our conversation is all about artificial intelligence, artera.ai, in the screening and diagnosis and better approaches to prostate cancer. Enjoy my conversation with Dr. Daniel Spratt. Let's go. Thanks for tuning in to this week's episode of the Dr. Geo podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel on youtube.com/Geo Espinoza ND. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time. Welcome to the Dr. Geo podcast. I am your host, Dr. Geo, where it is my intention to help you optimize your prostate health, testosterone, erectile function, and what can we do to live just a little bit better as we get older, calendar years. Great pleasure of having Dr. Dan Spratt here. Dan, thank you so much. The world is so small. I can't believe I'm actually speaking with you, because when this news on artera.ai came out, I was like, who am I I don't think I know anybody. And then I see you having a conversation with Alicia Morgans on Euro Today. I was like, well, that is a way. Through Dr. Morgans, I'll get to Dan, and here you are. Thank you so much for being on your busy day.
Thank you so much. Really appreciate the invitation.
So AI, let's have an overall overview conversation on AI, right? So we know that's, I mean, I use it now, right? I use it quite a bit in different forms. And it really just started less than a year ago. The whole thing with ChatGPT just came about in terms of, hey, it is a real thing. So I think that as we move along, it's going to be like, look, if you're not involved with AI to some degree or another, it's like not having a iPhone or a cell phone or a smartphone. All right. It's going to get to that. Perhaps and I read your paper in the New England Journal on AI and artera.ai and prostate. So to me, you might be more of an expert, certainly, than I am on the subject. So in that study, there was a 15-year follow-up, which is like, so this has been going on for a while in medicine. So give us an overview of what's happening in the AI world. How far back have we been looking at artificial intelligence in medicine as a whole, if you know that information, or for prostate cancer? And then we'll take it from there and get closer to the recent studies on prostate cancer.
Yeah, no, absolutely. I think you're spot on. You can't read any news feed without seeing the word AI a couple dozen times. So, AI's been around, even before the 1970s. And, it was in the 90s, a lot of us started seeing like AI beating, world chess champions. And, then it was on Jeopardy, and then a variety of things. And it's really in the past few years, as you said, that the amount of computational power, and it's really deep learning and these things called neural networks kind of thing of your brain. It's like how it's going to identify and interconnect features, we'll say, has just really incredibly taken off. You can go look at NVIDIA's stock to see sort of what's happened. But yeah, and so we've commonly, when we've tried to personalize medicine, yes, we look at patient factors, their age, their weight, their PSA, and then it sort of had this era of genomics, right? You're looking at specific genes or multiple genes, but all of that often it's I call it's human interpretable. It's human defined inputs. It's saying like I'm going to pick this gene and put it in and see how it works. But an alternative approach is, and this is basically what we did with our artera.ai, is you take a patient's pathology slide, which Dr. Gleason from the 1960s made the Gleason system, and that was sort of human pattern recognition.
Yeah.
He didn't train the Gleason score to say, oh, you need surgery or you need radiation. He didn't say that you're going to have this risk of metastasis. Just said, here's patterns I see. But if you can get really good quality data and a lot of it, you can say, what are all these features on this slide, pathology slide? Some we can readily identify, some we can't. Mm-hmm. And train it to effectively say, okay, which men are going to have more aggressive or less aggressive disease, as well as which men in this specific case to develop what we call a predictive biomarker, which ones benefit from hormone therapy and which ones do not. And it's looking at hundreds of features, some of which, like I said, we understand what they are. Right now, some of it we don't fully understand what they are. And it was able to be validated, as you mentioned, in the largest randomized trial ever done. It's called RTOG 9408, where half the guys got radiation alone and half the guys, they added a short course, 4 months of hormone therapy. And amazingly, that 2/3 of guys with this test, we can spare hormone therapy. So it's really exciting because myself and many others have worked for years, for decades, to try to identify how to best predict who needs hormone therapy. And we've never been able to validate a test in this fashion. So it's really exciting.
And why is that important? I know, actually right before we started recording, we spoke about some of the potential adverse effects from hormone therapy. Yeah. But go ahead and make believe we didn't have that conversation. Sure. So why is it important to determine, this group absolutely needs and can benefit from it. And this group probably doesn't need it and will still, be cured from their prostate cancer potentially.
Yeah, of course. So, as we were speaking of, the only reason you should ever take a treatment from a physician or from anyone is if they can help, in my opinion, improve your quality or your quantity of life. If they can't help you in the way you experience life, why are you taking that? And so in the case of hormone therapy, sure, in some men, it helps them live longer, helps prevent developing metastatic disease. But if it can't do those things, and in most men, it has what I call the common side effects, decreased libido, hot flashes, which I say are, those two are almost guaranteed, but it has a multitude of other side effects depending on the individual that range from bone loss, muscle loss, a decrease in vitality is sort of, I say a lot of guys that are like 60, 70 and up, they still got a lot of energy. And on Saturdays, they get up and they get to it. On hormone therapy, they're like, I've never, the wife will say, or their partner will say, I've never seen them just stay in bed, or they didn't do anything. It's a change,
Absolutely. If I can add to that. So as you know, I'm a naturopathic doctor, and much of what I do is natural and lifestyle. And from a prescriptive perspective, so guys on ADT, I want them to lift weights 3 times a week. And in a certain way, I kind of give them guidance. Some guys, they just will it. Let's put this in perspective. You are, I've learned, a workout person as well. You have a history there. I am as well. Under normal circumstances, we wake up in the morning and I tell people, look, I don't wake up and be like, I can't wait to hit the gym and I can't wait to do that run. I actually don't want to. I want to stay in bed like everyone else and cover myself and be snuggled up and whatever it is that I want to do. But, I just get up and go. So motivation, I tell people, don't wait to be motivated. That said, biochemically, no testosterone, there's a notch or two less of just wanting to do it. So with some of my patients on ADT, they really just will it. And I got to say, some of these guys, they're the most committed people I know. They just go, and I'm talking about a workout. They lifting
Yep.
weights, they're benching, they're doing everything they need to do because they care about their quality of life as much as their longevity. Yeah, lack of motivation once the hormone therapy. I guess this is for the listener who's on ADT. I
Mm-hmm.
think there's going to be quite a few. You can't wait to be motivated. Yes, no ADT, more fatigue and things like that. What I tell patients typically is, look, go for 10 minutes. If after 10 minutes you're like, this is horrible, I want to go home, go home.
Yep.
But even for all of us, once we are out the door, that's the hardest part. And I
Yep.
find that's the way with guys on ADT. And Dan, I'll tell you this, you're going to appreciate this. I measure their body composition before and after.
Mm-hmm.
Not only do many of them not lose muscle, which is a major element, some of them gain a little bit.
Yep.
Some of them gain a little with diet, right? So there's 3 ways of protein synthesis or muscle production: testosterone, protein, the right protein, and weight resistance. Well, they don't have the testosterone. I tell you, with the other 2 things, they keep a decent amount of muscle, which also means that metabolically they'll be healthier. So I just want to give that overview to you and to those that are listening that, exercise is medicine and diet is medicine. And if you're on ADT, you can keep muscle and stay relatively healthy moving forward. Sorry to interrupt, but I just felt
No,
that was the right time to mention that.
I completely agree. I've said, it's interesting you said, 10 minutes. I actually, that's literally what I tell all of my patients. I say, you need to do 10 minutes extra per day
Mm-hmm.
of exercise to maintain approximately your body composition. Again, that's a rule of thumb that I use with them. And yeah, I mean, think about it. There are postmenopausal women
Mm-hmm.
that have functionally no testosterone. And you look, and there are some very fit, I joke about like the Madonnas or Janet Jacksons of the world. I mean, they are muscular, they're fit, they've developed it as they age. Men can do that as well. But to your point, it is, you need a healthy, amount of protein intake. You need to watch the other things you're putting in, and you do need an amount of resistance exercise because bones and muscle, one of the few things that will tell them to grow is resistance training.
Mm-hmm.
I'll never say cardiovascular activity and running is bad. It
Mm-hmm.
has other good functions, but you're not going to see a long distance runner have necessarily strength or muscle. And we're on hormone therapy where it's lowering their testosterone in many men who are not normally very active,
Mm-hmm.
adding. And so the cheapest way, if they don't have a membership to a gym and there is no outdoor free facility, is you can buy very cheap resistance bands now that can
100%.
give the average guy, it's 10 minutes. If you want to do more, and a lot of them, you're spot on. This is their kick in the butt or inspiration, and they lose body fat or they gain muscle on it. And so I think that's equally part of the physician's responsibility. If you're prescribing hormone therapy, to me, that goes hand in hand with it.
I agree. I protect you guys from that. So because look, you're
Or
right
to
on, or
refer to someone who's
you
focused.
you you don't
Exactly.
you don't you don't have, I tell them, they don't have the time. They're seeing so many they really don't have the time and so forth. But I think the takeaway is that, yeah, resistance bands. I have patients get kettlebells, not that expensive.
Yep.
Store it in a corner, get different, because you need a decent, at some point you need to continue to kind of challenge yourself a little bit more with just a little bit more weight. Back to artera.ai currently, the way it's used is, and do you know if NYU were using? I have no idea if the guys. I haven't spoken to anybody. Or who's using it these days? Artera
Yeah,
AI.
so he just got EMS approval in January, and then really kind of got amplified as an option to be
Mm,
used in our national guidelines, the NCCN
that's
guidelines.
right.
And so I think that there was a variety of, like in anything, there's early adopters and there'll be late adopters.
Okay.
I think there's a variety of places. Most of the data started in radiation oncology
That's
clinics
right.
because it's helping, especially guide the use of hormone therapy. There'll be some real exciting data coming out at the AUA this year of a new model from Artera for men who undergo surgery, prostatectomy.
Oh wow.
So I think I think we'll see sort of increasing adoption as obviously the information gets out and people get comfortable, with the test and data.
Can't wait. So currently, the way it's used is to determine who benefits from ADT or androgen deprivation therapy while undergoing radiation therapy, or independent of it, or both.
No, correct. So it was trained for men predominantly with intermediate risk prostate cancer, so mainly like Gleason 7 disease, that we often will prescribe radiation with a short course of hormone therapy for many of these men. And that's really the intended use. And it may work in other settings. It's just we haven't validated it. And so I would say, like any test, caution to use it outside of really where it's been trained and validated. But for right now, that's the main indication.
I almost feel like that's sort of a limitation, right? So Gleason 7 intermediate, Gleason 8, ADT, you said ADT for 4 months. That's what was studied. ADT for 6 months, ADT for, oftentimes they're in it for a whole year.
Yeah, multiple years. Yeah.
So is there applications there, even looking off label, if you will?
Sure. Yeah. So it'll probably get sometime this year added to the test report, but at the end of last year, this isn't published yet, but it was presented at ASCO by Dr. Andy Armstrong, is we developed for higher risk men, as you said, Gleason 8s, 9s, 10s, where the standard of care is actually giving a year and a half, 2 years of hormone therapy, testing to develop a comparable biomarker ish. Can you just use short term, 4 to 6 months instead of years, and similar performance? It's a different model, so it's not the exact model, but to a patient or a physician, it's kind of behind the scenes of what it's looking at on the slide. And so hopefully that'll get rolled out this year to help with that decision, because again, there's a pretty profound difference in the side effects of 4 months. It's an annoyance, but years of hormone therapy can take multiple years to recover testosterone.
Yep.
And that's with that accumulation, right? We all know as we age, it's easy to look down and be like, oh, my belly is a little bit bigger over the past 5 years. It's something that I think that those side effects of hormone therapy can accumulate.
For sure. I think you mentioned something really important that no one talks about. Once I'm on ADT, how long does it take for me to recover my testosterone? And it could be a long time depending on how long you're on it, right? So it could be a year, 2 years, and no one is really talking about it. And I think that's an important point as well. Some people think they'll recover right away and they get their, zip back and their step back and their libido, and it's not quite like that. So I treat those patients until they are about even 250 total testosterone. I treat them as if they're still on ADT with certain protocols that I think will help them. And then once they hit a certain point where they're saying, wow, I got my libido back, so there's a decent amount of free testosterone and things like that, then we'll move on to the next approach. But that's an important point. What are the numbers from your study in New England Journal? So guys so what's the predictive value when they are an ADT, and is it EBRT? So external beam radiation therapy?
I mean, there was a small subset that had brachytherapy, but most of it's external beam radiation. Yeah.
So what's the predictive value there with being on ADT while RT and not? What percentage do what?
Yeah. So, if you are what we call biomarker negative, which means, you're predicted to not benefit from short-term hormones, which is about 2/3 of men, then it was less than, it was about 0.5% difference 15 years later in outcomes like developing distant metastasis or dying of prostate cancer. So, definitely not statistically different at all. The curves are basically superimposable. But if you're in the biomarker positive group, which is about 1/3 of the guys, it's, it's about a 10-15% benefit or reduction in developing metastatic disease or dying of prostate cancer. So
in the group without hormone therapy.
Correct. Like adding hormone therapy significantly reduced distant metastasis or death from prostate cancer by a fairly large amount, but just in those, artera.ai positive or biomarker positive patients. The negative patients, adding the hormone therapy functionally didn't change those outcomes.
What do you mean by biomarker positive or negative?
Yeah, so when the test is done, basically a tissue slide is sent off to be digitized, and they do the analysis on it. Basically the machine learning or feature extraction. What comes back to the patient and physician is a test report, and
Mhm.
basically the model will either say you're predictive biomarker positive versus negative. Positive, you could think of it as like if it was a gene, are you BRCA positive? Or are you
Mhm.
BRCA wild type
Mhm.
or negative? So
Mhm.
to sort of make it a binary, rather than like a gradient scale. So if you're positive, you're predicted to have a large benefit from hormone therapy. If you're biomarker negative, you're predicted to have minimal to potentially no benefit from hormone therapy.
And so, Dan, what's the input into the system that gives you positive or negative? So, positive nodes, or cribriform positive. Like, what's in it? Gleason
Yes.
scores.
So that's the whole, I so there's two pipelines that go in. So one is the clinical features, the PSA, the patient's age, T stage, Gleason primary, secondary. That stuff gets fed into the model, and then the pathology slide from their biopsy, it's extracting hundreds of features from it, and through this sort of deep learning, it has a model that basically will assign it based upon those features. Is this a positive score or a negative score? And this is where I was sort of referencing with AI. People talk about the black box, or they'll talk about explainability. Like, how does, when you log on to Amazon or social media, like how does
Mhm.
it know what's what you want?
Mhm.
Sometimes it can't always fully be explained. There's a lot of research going in with artera.ai and just in the field in general to unpack
Yeah.
what exactly on that slide, like which part is driving it. And that's why I say large data sets with very robust validation. So it's been validated now in another like 4 randomized phase 3 trials. I can't emphasize enough the need for robust validation and generalizability.
Hmm. The slides that are sent to inserted into the system, is that
Yep.
after a pathologist reads it and say this is this, that, and the other, or aside from that?
Yep. So it is that after pathologist, usually it's a local pathologist. It's just a single H&E slide. So one of the nice things is it's not what we call tissue destructive. Like you're not, you know, using the tissue up for anything. The slide just gets sent right back once
Mm.
it's digitized. And I think, I'm not part of the company, so I can't tell you the future plans, but my guess is where most of the field is moving is more and more places are getting digitizers like at their pathology labs. So
Mm.
this may be something that turns more into, you do it locally, your pathologist technician, whatever, scans it in, and then it goes into obviously needs to be hyper secure, but like the cloud,
Mm.
and you
Mm.
pretty much instantaneously get your score back.
Mm.
So rather than having to mail off a slide to be scanned.
Let me potentially try to ask even a better question.
Yeah.
What's inserted into the system, to the AI system, is it the pathologist report,
Oh
Gleason
no.
9, cribriform, or
Yeah.
does the system get the slides and it develops its own report, like replacing the pathologist?
So yes and no. So yeah, it's not taking the path report at all, other than the Gleason score. And actually, the newest model, I believe, they're getting rid of even using the pathologist read Gleason score to just say only look at what is seen on the slide. So I think that there is. I was speaking recently that there are a variety of models. Like there's a companies that will detect is it cancer or not. And so pretty much as accurate as a pathologist. And so yes, is the field, and many pathologists have said this, so I don't think I'm saying anything that expert pathologists wouldn't necessarily agree with. I don't think they're all on the same page. But yes, I do think that there are models available that just you would take the H&E slide from the biopsy with no pathologist reading it, and it could tell you, is it cancer? Yes, no. What's the grade of the cancer? and run through algorithms like artera.ai and tell you, would you benefit from hormone therapy or not? And so all of those components aren't under one, company's roof. But I think, again, as people start buying digitizers and these become models you can run, and, I'm sure it'll start in, I don't want to say it's the private practice sector, but I'm sure there'll be large consortiums that'll just say the efficiency of this is so powerful, who don't have all the subspecialists like, at NYU where you are, you have subspecialists.
Mhm.
Not every practice in the world has that. So they would probably preferentially benefit from something like this.
Absolutely. So you know the challenges, and this is why I'm asking, right? The challenges are that you are primarily you. I mean, people that come to see me, they're already sort of diagnosed most of the times anyway. But everyone else, urologists, radiation oncologists, they're treating based on what they think they have, what they think the patient has,
Mm-hmm.
and you also know there's a lot of false positives, not intentional, but information where Gleason scores get upgraded or downgraded, right? Because these are
100%.
humans, and I've seen it. I've seen. You would think it's just from a Gleason 8 to a Gleason 7. Well, that's significant. Yeah, that could be intermediate risk to high risk,
Yep.
right? And so we've seen that. We've seen also from radiologists information that's inaccurate, right? So they read an MRI report, it's a PIRAT 4, send it somewhere else, it's a PIRAT 2.
Yep.
How can that be? So I guess the question is, I mean, will there be a time where radiologists and pathologists be replaced by artificial intelligence?
Yep.
Like, where are we going with this?
Yeah.
And number one, which obviously we don't want anybody losing jobs, but number two also is maybe that's where their value is with AI. It's like it's way more precise, so we can all make better decisions as to how we treat these people.
Yeah. No, I think, and people have probably millions of people have said this statement that, people's jobs, pathologists, radiologists, they won't be replaced. It's those who refuse to use AI, those pathologists, radiologists will be replaced. And I can tell you already, many places are using a lot of AI tools in radiology, and they're just coming out like lightning speed. And radiation oncology, we have auto contouring, basically AI derived preliminary contours for our normal tissues, not the targets that we're gonna be intentionally treating. And it's an efficiency tool, and I kind of compare it as a typewriter versus Microsoft Word with a little squiggly line that you spelled it wrong. It's an assistant, it's helping you, and I think that for a while it's going to be something that's going to dramatically improve accuracy and efficiency. And I think that hopefully good doctors will, if there's something that can do it better than me, that's what I want for my patients. And I think that I have other value and there's other skills I can learn. But right now, I am excited beyond belief to have these tools to not only improve my own efficiency, but eventually it'll surpass my accuracy. So yes, it is absolutely coming across medicine. I mean, I think in all industries. I mean, so the AI voice generators, I could train a copy of your voice, right?
Yeah.
But it won't have your brain, and so it's
a tool like any other, like ChatGPT or any other tool. I
yeah,
don't think ChatGPT should replace writers, for
correct.
example, but is a tool that writers can use to. I've used it to. It's giving me more ideas. For example, it's like, oh,
Yep.
I didn't think about that, and things. So it's a tool. Where do you think this is going to go? So, well, this patient, sometime in the future, this patient benefits from a prostatectomy more than radiation. This patient, should be, even better at selecting patients, for example, for active surveillance who have a higher Gleason score than a Gleason 6, perhaps
Yep.
Gleason 7, 4 plus 3. No, this patient with a 4 plus 3 actually is a good active surveillance patient. Like, where is this going? What do you know? What's in the pipeline that you know about now, and where do you think it's going to go?
Yeah. So I think that it is almost unstoppable at this point, and so companies like Epic. I don't know if NYU's on Epic. So
Epic, yeah.
Epic's the lion's share of EMRs. They've partnered very closely with Microsoft, which makes OpenAI, which makes ChatGPT, and I think that the amount of data that they have in something called the Cosmos is hundreds and hundreds of millions of lives, unbelievable amount of detail and data that we hopefully will be not simply focusing on the Gleason scores or PSAs or pathology slides. And as you and I have talked, I think equally important is patients' overall health status, their other labs.
Yeah.
I mean,
Yeah.
I've never seen a nomogram that takes someone's hemoglobin, testosterone levels, if they're married, if they're sexually active, into
Yeah.
a quantitative decision.
Yeah.
Good
Yeah.
docs will say, like, yes, we talk about, but
Yeah.
that to me should go in that if you have a guy who's been on testosterone replacement therapy and is clinically depressed, not being on it, and he has basically borderline indication for ADT, I would hope with AI that you'll be able to have something that says, caution with using ADT would be the answer. It's not saying don't do it, but that to me would be the recommendation is hits caution because you'll probably hurt more than help. It won't take away that human connection, but I think there's so much more of the entirety of that patient. There are social determinants of health, a variety of things that need to be factored in, drug pricing costs. That data is all available, and I'm sure you, in your mind, you have some way of synthesizing it for that patient in front of you. We all do, but it'd be really helpful. And I think if you had a nice report of all those factors that you kind of go into decision making, beautifully laid out, and you could get years and years of information on that patient. So I think it's coming, and I'm hoping it's coming in a way that is truly patient centric to provide better shared decisions, and it's not a binary that this will lower PSA, that we can try to get more towards we are making patients experience life better. And sometimes it is lower PSA, sometimes it's not.
You mean the patient stimulated anxiety biomarker?
There you go. Yes, exactly. I mean, PSA is, I say this often that, adjuvant radiation after surgery, PSA is what guided us wrong. Active surveillance, PSA guided us wrong, and we didn't do it. It's very good. I don't want to. PSA is a super important.
I agree. I agree with everything you said, including the fact that it is important. Touch will say, look, there's less than 10% of people walking around the world with high PSAs, so it shouldn't be high. It's not like, it's not like just but it's how do you utilize it, right? So yeah.
Correct. And I think one of the things that I speak a lot about is it's failure. We talk about active surveillance. People are like, oh, my patient has so much anxiety, like, they see their PSA rising. And I say that's a failure on the clinician. It is our job to make sure they know that our treatment will harm them more than help them. And whenever you frame it like that, I have never had a patient that is like, treat me, doc, you're going to hurt me more than help me. And so that's on us. And I don't accept the excuse that PSA has to trigger an intervention. If it's going to help the patient, then yes. But anxiety is usually because there's a lack of understanding or they're fearful. And that is our job to tell them if it is something that we need to intervene on or not. And not all PSA rises need to be intervened on. Sometimes they absolutely do. It can be life-threatening. So it is definitely not always.
Yeah, I tell people, look, I'm interested in your PSA, and certainly I know from a psychological perspective we can lower it. For example, Dan, I see a lot of patients with a recurrence after treatment, and what I attempt to do in that scenario is how long can we keep you before you have to go to the next thing? And so that then we have to look at this number. We have to look at the PSA because that is the determining factor oftentimes. But I tell people, look, I treat people. I don't treat numbers. I treat you as an individual, and then we can see what happens with your PSA. Again, I'm still interested because of the PSA is everything in terms of determining the next step. A utilization for AI, there could be, exactly that. Rising PSA, in a patient that's been treated, what is the probability of metastasis and so forth? That's more accurate. We got numbers, we get some data from Decipher and some of these genomics, but even more, that they can, with peace of mind, say, look, I can delay treatment for a year, 2 years, 5 years, or maybe longer. Since we really don't know in a recurrent situation, having conversations with some colleagues have said, Gio, the reality is that I would wait until something comes up on an imaging before starting to treat them with ADT or something stronger, abiraterone and enzalutamide. But the patient oftentimes won't, and won't want to do that or take the risk because of the fear that we've created around PSA. What are your thoughts on AI in terms of that utilization of determining, in a recurrent situation, who needs treatment, and outside the box thinking? We know recurrence, let the PSA go up, velocity matters and all these things. I get it, but see what's until something comes up on a PSMA PET scan before you start treating. Your thoughts?
Sure. Yeah, I think that in every single clinical trial, even like phenomenal ones, you're lucky if you get let's say a 10% improvement in whatever the outcome you're measuring, whether it's metastasis or death. I mean, sometimes you get a bigger benefit, but let's say it's 10%.
Mm-hmm.
So we call that a number needed to treat a 10. That means you treat 10 guys, 1 benefits. Mm-hmm. That's a very good ratio, but that's still 9 guys that did not. And in a lot of our treatments, that kind of metastasis or survival benefit is even smaller. So it's all about, I say biomarkers, and there's a lot out there. Like Decipher's one of them that can help in many situations. But I think that in this recurrent setting, it's how do you run look at the prior trials that have been done, conduct new trials, and get to that ratio where can we get that number needed to treat to be like 2 or 3? I mean, it'd be great if it was 1, where you only treat the guys, but to even limit it down to that person who's really going to benefit, and then make it so, because we have guys in settings that probably a lot more should get treated but are not because of I don't know if it's really going to help me. And so instead of really focusing on who needs that treatment and benefiting those men, I think that it's often stated, and I don't want to say it's not important, but people will often quote, in metastatic hormone-sensitive prostate cancer, no question, the randomized trials will show that adding at least a doublet, adding an enzalutamide, darolutamide, Abi, Enza, is the standard of care. Every trial is positive, no question. And they say about only 50% of patients get more than just ADT. The challenge with that is I don't know which are the patients getting it, because there might be 85-year-olds with heart disease that these drugs might be hurting more than helping. And there might be a 50-year-old with bad cancer that's not getting it. And so it's how do you actually get these powerful, maybe life-prolonging agents to those who benefit, or keep them in your back pocket when other patients may not quite need them yet.
Right. And there again, perhaps yet another application for AI to help us figure those kinds of things out. So what do we have currently? So this is 2024. What do we do with artera.ai? It's only applicable in situations to determine if a patient with intermediate prostate cancer, roughly Gleason grade 2 or Gleason grade 3 as well, right? Gleason 7, 3 plus 4, or Gleason 7's 4 plus 3 studied as well? Yeah.
And so I probably should have clarified. So
go ahead. Yeah.
There's really 2 components right now available. The much broader is a prognostic model from Artera. And so you could think of it like Decipher or like a Gleason score on steroids. It's telling you a much more accurate prognostication, how aggressive or indolent your disease is. And that's across the entire risk group from Gleason 6 to 10. That's, the whole gambit. Regarding the predictive test, that's specifically for intermediate risk patients to guide that decision of, because a predictive test needs to say, okay, what's the treatment? Well, in this case, it's short-term hormones. Well, that's recommended for intermediate risk men with radiation. But the prognostic test, the Gleason system is not very accurate. it's not only is there subjectiveness, and it's about 75% experts agree. That's not great.
Mhm.
But even amongst experts,
Mhm.
when you look at how well it discriminates who has aggressive or indolent disease, it's not excellent. It's moderate.
Yeah.
So I think that that's the point of the prognostic Artera test, is to give you a lot more confidence that this is aggressive or indolent disease, to maybe help you make those shared decisions with patients.
Beautiful. And currently, the situation is only for radiation, hormone therapy, with or without hormone therapy at this point. That's the utilization of Artera AI currently.
Just for that predictive model. So you
Yeah,
can
right.
get it on any patient with Gleason 6 to Gleason 10 to understand the prognosis, like how aggressive the tumor is. Like, what's your chance of developing distant mets or die from
Yeah.
prostate cancer? And you can order it for guys getting surgery if you want. It's
Oh,
been
you can.
correct. It's been trained and validated in a lot of radiation randomized trials, but the prognostic model, like the definition
Understood.
of
Understood.
a
Yeah.
prognostic test, kind of like Decipher, is it doesn't really matter the treatment you get. Like a Gleason score of 6 does better with surgery, radiation, hormones than a Gleason 10 does. So
Got it. Oh, I didn't know that. Okay. And so if patients are listening and they say, all right, what's the conversation like? Because I'm not seeing, I haven't heard too many people offering it because it's too new and it was just
yeah,
approved. So it takes time. What should they do? If should they find clinics that have, if they could, that are utilizing Artera AI, or what can a patient
yeah,
do to benefit from its use?
yeah. So I mean, I think hopefully, just talking with whether it's your urologist, radiation oncologist, whoever your prostate cancer doc is, ask them about it. You can go and just go to Google or whatever search engine you want, type in Artera AI and go to the website, and there's plenty of information there. It's a very simple process. Basically, one of your pathology slides is sent to the lab with some of your clinical information, and it's about CMS covers the test, so it shouldn't be a cost. And I think right now you need to contact Artera what's going on with private payers, if there's like a cost recovery type model. I'm not totally sure, or if there's a period where it's like deeply discounted, but they should just, I think, reach out to the company.
So is it as simple as I'm their practitioner and I contact the Artera AI? I say, look, it's like ordering a genomics test. They take care of it. Once you insert all the information, they take care of it. They place the order and then let the patient know what the fees are, if
Yep,
any.
it's an online portal. You put in some info, and you hit submit, and then basically goes from there. So it's very analogous to some of the genomic tests. It ends up being faster, just because you don't have to do the complex genomic, extracting of the RNA and everything. But it's very similar. And instead of you only send a slide, then usually you have multiple unstained slides and tissue blocks. So most institutions are much more willing to depart with a pathology slide than they are to send off actual tissue blocks. In fact, some centers really don't want to release those. They want to keep those blocks for internal or future use. I almost think they view it as like IP. So they're very hesitant, especially from an outside hospital. If I said, hey, I want to go I have a patient I'm treating that had the biopsy at your hospital, we want to send it off. There are a few centers, and I won't name them, but they're big name centers that put a lot of roadblocks into that.
I know one of them that's in
Yes,
New York, actually. I don't
yes.
know. There are many, we didn't say, there's many institutions in New York, so I know one of them. Dan, thank you so much for your time here. I really appreciate you being on and kind of sharing this information that I think that, man, we're just scratching, we haven't scratched the surface yet where this is going to go. I consider you a leader in this space right now. And again, thank you for being on. Final words, and how can patients be in touch with you or your office if they want to make an appointment?
Yeah, no, appreciate it. So if people more than willing, you can email me and I'm happy to put that on the podcast. That's just daniel.spratt at uhhospitals, that's plural.org.
That is with two T's at
Yep.
the end.
Yep. SPRATT. And hospitals, there's two H's, hospitals. You can email me. You can probably go online and look up UH Hospitals, your University Hospital Seidman Cancer Center, and get an appointment. Happy to answer questions. I really appreciate being on. I think this is fantastic what you're doing. I think it's really important for men and other listeners to be hearing.
Hey, thank you so much, Dan. Hey, everyone, thank you so much for listening to yet another amazing podcast episode with one of the experts on artera.ai and artificial intelligence and how do we utilize it for prostate cancer specifically. I know you found this valuable. Thanks again for being on. Stay well, stay healthy, and make it a phenomenal day. See you next time. Dr. Gio signing off. Thanks so much. Thanks for tuning in to this week's episode of the Dr. Gio podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel on youtube.com/Gio Espinoza ND. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgio.com. I'll see you next time.